They're going to go through some updates from the LMC, what we've been working on, and then answer any questions that practices have. So Mike, I'm going to hand straight over to yourself, if that's okay.
Yeah, of course. Yeah, let me just pop this up. So apologies, not everyone likes PowerPoint, but I think for me, it just gives us a bit of a consistent approach to updating you on what we're doing. And I can then update it each month. So this is our kind of strategy update. So we've talked as a committee now for a while about what we should be focusing on. And so we talked to you last month about this, and I just want to update you. So the three areas, hopefully you can see this. Can you see this on the screen? You've got the PowerPoint?
Yeah,
okay. All right. So the point of this really is just to update you as to where we're going, what are we doing for you, and do this every month. And then once James has had his update as medical director, then we're kind of here and we can take any thoughts, questions, comments, etc. So what we did talk about a while ago was that our three main areas were around reducing the workload from the other sectors into general practice. That was the main feature. Improving the financial stability of practices and safe working. So they're the three areas that we're focused on. So I'm going to take you through what we're doing and where we've got to so far. Okay, hopefully on your screen you can see number one here, which was really what we're doing about the unplanned work shift from other sectors into general practice. So I'm just going to breeze through some of this, but you know, as I say, can quite happily talk at more detail at the end and go back to some of these slides if you want us to. So there's work going on. We've still got this survey at national level with the GPC, so the BMA, and they're helping us really in all of our LMCs in terms of national action. It's going to be interesting to see what happens with a new government, but I know that Katie Bramwell-Stain has been in fairly regular contact with Wedge Streeting before the election, so she's got a head start on that one. But of course, you know, that's something that's going on. Now, I've put on the slides about the Northamptonshire letter to the system. So this was just to let you know really what some LMCs are doing. We haven't done this, but it would be interesting to take views on it maybe later. But what Northamptonshire have done, for example, is that they've written to their ICB and they've said that as of the 1st of May, they're stopping doing any of this work that shifts in. So essentially what they're saying is that any referrals that they get asked to do differently, or any of the paperwork that comes back, or fit notes or medication requests, etc., that they'll send back. So they'll literally send it back to the hospital and go, we're not doing a fit note for that patient. You should have done it, so you can do it, and we're not going to do this anymore. Now, they've got that for a number of things, which we've not gone to that point, and I think most LMCs haven't. But it's interesting what they've done, and they must have confidence that their practices will stand behind that to even write that letter to the ICB, unless it's really just trying to draw a line under it and saying, look, this is your problem, not ours. As I say, we haven't done that, but we are open to ideas. We are open to feedback about how we improve this situation. I think the concern that a lot of people have is that if you have a patient in front of you and you say, well, it's not our problem, it's the hospital's, then you get into a really difficult situation. But some LMCs decided that's worth it because it's not their problem. It's up to the system to sort this out at trust level. That's the view that you could take. At the moment, we're trying to still work on it between us, and we'll talk a bit more about particularly what's going on with NUH, because that's where the most of the good work has been happening, which we need to replicate. So our committee GPs, they're assigned to reducing work shifts. So we've got now some of our 19 GPs, hopefully 20 soon, but we've got them taking parts of the strategy and to start working on that. So we're going to talk about that tomorrow night at our committee meeting, and you'll be able to see the committee minutes from that if you want to. It's all about transparency and what we're doing for you. That's hopefully the biggest change you're seeing, a lot more out there about what we're doing behind the scenes. We've said this before about understanding the quantity of work shift and where it comes from, and the use of eHealth scope. I think our problem is still the same. If we're going to set objectives, we need to understand the start and the end. So we have done an audit ourselves in the committee, which we're using as a baseline, and then we can obviously repeat that in the future to see whether there's been any improvement. Because anecdotally, it feels like there's a lot of issues. We just don't know the size of it, and therefore we can't really say how it's improving. What we can see, though, is we can see where things are changing in terms of the relationship with the trust and how seriously they're taking it. And we'll talk a bit more about that soon. So there is a lot of interface working with NUH. There's been a group that's met now for some time, with colleagues from the place, people like Hussein Mauji on it, excuse me, and other colleagues, lots of GP input into that. So, there's no doubt that there is regular work with the hospital, particularly with NUH, which we're trying to duplicate now with Doncaster and Bassetlaw, who we met last month, and Sherwood Forest, who we're meeting next week. And there is work going on with those as well, but I think it's trying to share some of the learning that we've had with NUH. I will show you a slide that NUH is showing to their own teams, which tells you more about their own responsibilities and how they're taking it seriously. And we had an interface meeting with Nottinghamshire Healthcare Trust last week as well. So a lot of the mental health provision, the community services through Notts Healthcare Trust. We had an interface event last Wednesday with NUH, so that was attended. I think the sign up was around 80 to 90 people. That was held at Notts County in an evening last Wednesday. And that was interesting. And I guess one of the main things that came out of that for me was that they were suggesting that they might open a new alternative email address for concerns or feedback. So an alternative to eHealthscope, but a way of getting immediate feedback. And they talked about some of the innovations, and I just don't know how well known this is in general practice in our area. But one of the innovations is where if you're having a problem with a disposition for a patient, you're trying to deal with a patient, you're trying to phone somebody in the trust at NUH, you can't get hold of them. There is actually an alternative way of getting hold of a consultant, Mark Simmons, who helps out and helps to sort this out when it happens. So we kind of need to make sure that people are aware of how to get hold of these people when you get any problems with NUH with a patient, because there's lots of things being set up, and I just wonder how well known it is. We've also got a new medical director at NUH as well, who was there for this event last week, and again, probably quite helpful really to be in their eye line really from the start. And what I can say about NUH, and it's not perfect, there is still work coming through that shouldn't be coming through. I can guarantee from the work that we've seen them doing that they're taking it seriously, that they're putting resource into improving the interface between general practice and secondary care. Where it's not working, we need to raise it, we need to show what's not going right, but I guarantee they're working on this very hard. And we're working with them. We meet with their leadership, including their CEO, for a regular strategic level meeting. And I also work with Simon Gascoigne, who's in the interface team with NUH. They have an interface team, and meet him every month as well as all the other interface we've got. And James might tell you more as medical director about his work, because he certainly gets involved in those weekly interface meetings as well with a group of GPs. So there's an awful lot going on, but what you'll be interested in is how's that making an impact, and that's what we need to do better. This is a slide that NUH have done for their colleagues in the hospital. I actually asked them to change some of the wording for this for the event last week, because actually this is contractual, and it's really about how to help patients. But of course, it's going to help you in your practice if they do this consistently. So this is an NUH slide. It hasn't got us on it at all. It's from the Deputy Medical Director, Alan Harcombe, who's a cardiologist, and he's working on this interface. So he said clearly that NUH, their colleagues need to communicate clearly and concisely, and make it clear where there's actions for the GP or the patient. And that really ought to be at the top of anything they send, so that you can very quickly spot if there's anything you need to do. If a patient needs to be referred to another speciality in NUH, then that should be done by the person in NUH themselves rather than send it back to the GP. If it's in relation to the original problem. They're getting better at this, but what some of the feedback we had from this when we've told people and reminded them is that they just didn't know. There's consultants, there's specialists, there's people on the wards who didn't realize that was something they had the right to do. So, we kind of have to understand how much of this is people taking the easy way out, the quick way out, send it to the GP. How much of it is that they don't understand that this is something they can do, and how much of it is that they just find it hard to work with it themselves? I've had the quote to myself once, which was something along the lines of, "You'll actually get them through quicker if you refer externally than if we try and do it internally." Then I quickly reminded them that this was one of your contractual duties. So we need to all push collectively to the leadership if it's a problem internally with the hospital, but they should be doing this. So again, they didn't all realize this. There's quite a few contract changes came in about 7 years ago, and there's still people working in the hospital who don't know them all. It's not even that they're trying to push this work. They just don't understand that this is something they should do. Follow up the results of tests you've undertaken, including the patient receiving results and any actions. So they should be doing this. So that was a reminder. Issue a fit note where appropriate for the full duration. We've heard all sorts of stories on this of people getting, a few days or a week as standard, and they've broken a limb. So you can quite easily anticipate how long somebody might need to be out. Because of course, it doesn't mean that they can't come back early, and they might come back to you early to see if they can come back. Equally, there's no reason why it can't be extended. So we're trying to take the risk out of that and say, well, look, just make an educated decision on what you want to do here, but actually give people a useful fit note. That doesn't mean that they come back to the GP within a week to get a longer one, because you can do it from the start. And again, that was accepted. And it's daft, isn't it? But sometimes it's things like pads of paper being available to write stuff down, and prescriptions was on as well. And actually what was said quite clearly was around e-prescribing and how that really isn't commonplace in the hospitals. But hopefully within the next 12 to 18 months, we'll see that adopted in the hospital at NUH. So that will improve things as well. But a lot of this is slow, and a lot of it is still, we know that the computer systems in general practice isn't great. Actually, in some cases, they're even worse in hospitals, believe it or not. But there's a commitment. What we're seeing visibly is NUH standing up and saying, we shouldn't be doing this. GPs shouldn't be getting this, and telling their colleagues. There's 18,000 staff in NUH alone. And that's not all people on the wards or interfacing with us, but that just gives us a scale issue here. It's not the problem that they don't want to do it from a leadership point, but they have to educate everybody who is doing this work and who is currently sending it back to you. It needs to stop. I don't know if it will ever stop 100% because we don't employ robots, but we do need this to be a lot better than it is. I'm convinced that NUH are taking it seriously, but we need more. Objective 2 was about safe working. So we've got to be careful with this, because some people dismiss safe working as rationing care or just capping up to 25 appointments a day or whatever it is, or changing 50-minute appointments. Now, these are all things that are optional, but it's the tip of the iceberg. What we want to get is a culture in general practice where you feel that you can take a break, where you feel that it's somewhere that is actually looking after you as somebody who works in the practice. And it's hard to do that when you feel that you've got all this demand on you, and that anything you change is just going to cause more disruption or more patient complaints. But we're determined that we want to help you to try and do more of this to help yourselves. So it's building on the work we did at the late 2022 for anyone who went to that event in Annesley at our offices. We've got, again, GPs assigned to this. So there's GPs working on this for you at the moment. And we're funding some of this work. So we're funding work around automating work. So there is a project going on with auto filing of results. So how you can safely auto file and save a lot of the hours of people doing this manually. That's going on at the moment. We're hoping to see some good things in the next couple of months and be able to spread it across the area. It's been focused more in the south and in the city originally, while it gets refined, and then we'll be able to share that across the whole area. And again, we're putting money aside. This is money outside of the core levy that you pay, that we've frozen since 2010. This is money that we've taken aside from earnings from the buying group that we can play and use for you, for our strategy to make it real. Understanding capacity and access to change how the staffing is used. This is from an initiative in Rushcliffe that's got a good dashboard. It's got some really interesting things, and the way they've changed how they develop and change their team, it's been really, really cool. And we think that's replicable, but not a drop into another area and just make it happen. This is about leadership at local level and understanding some of the techniques that they've used and the technology that they've used. We can get the technology, we can help to spread it, but we also need to help you to work differently in your teams to make that useful. And in time, what it will do is it will hopefully change the way that people access you. It will allow you to have more time to see people, And it will stop being this kind of, eat all you can eat buffet of general practice, which is the model that everyone is used to. We shouldn't be celebrating the number of appointments that we see. We should be celebrating that they're safe and that they're of good quality and that we're seeing the right people. And we've got a task force approach. So we've got locality teams involved, mostly again in the south, and we're working with PCNs. We've got discussions with West coming up, and we've had discussions with Rushcliffe about how we can work and kind of approach some of what they've done and take it elsewhere. And patient representative bodies. So we met with the HealthWatch CEO last week, and Sabrina came in really with what number one aim being to talk to us about access, and I think went away understanding that we need money for the contract to change the staffing, but actually what we should really be talking about is is how we help the patients to understand the situation with general practice, and we're realistic about expectations, and we take this as a system problem and a national problem, not a GP practice problem. And actually, that's where we should agree with our patients. If they're unhappy with what they're seeing, we should agree and say, yeah, it's really difficult. We'd like to do a lot more. We haven't got the funds to do it. We can't employ more people. We can't employ more GPs. We'd like to do more stuff. So we have to change how we work. And this is what we're on about with Safe Working. We've got an open letter to patients that we sent, and that's been circulated, and our new MPs will be seeing this and hopefully having conversations with us about it. And that's to try and give a bit of air cover, a bit of top cover to the practices in your reception teams. Because again, there's no point arguing with our patients. If we're finding it hard to do everything that we want to do, then we should be honest about it and say, we're doing our best, we're doing what we can. And we've got people who could come and work and help us with capacity, but we can't afford it. Let's be honest about it, and let's make that a system issue. Let's get them to write to their MP. We've got a new government. We need to keep this push on. I don't think the push is going to stop. I think the BMA push will continue. We need the government to make good on what is being asked of them. The BMA are asking for it at national level. So let's keep doing it locally. And when you've got an upset patient because of access and you're trying your best, give them one of those letters that tells you to write to the MP. If they can do it electronically, then we can give them the link to the MP address to get them straight to that, to be able to write to them. We've got a whole new group of MPs for the most part in our area, apart from one or two, but most of them are new. There's a chance for us to get in there. Increasing the financial sustainability. So I'll speed this up a little bit, but this is the work where we're trying to help really with understanding where the pressure is, what's causing problems, make sure the ICB are aware. Now, it is difficult with the ICB at the moment. The ICB, if anybody attended any of the engagement sessions over the last couple of weeks, it would be interesting to hear your thoughts when we open the microphone up to you, because it'd be nice to know what you took from it and what you understand and how you feel about it. But obviously what the blanket answer is for anything around money is that there's no more money. Now, we can't be okay with that, can we? We can't give license to just not invest anything more in general practice for the next 2 or 3 years. We need to do something about this. So we've still got this work ongoing with the accountants. That has been slow, and we're going to go to a different accountant soon if we don't get something very soon. But that has been plodding through treacle, unfortunately, so far. We're linking in with other LMCs. So I run this LMC support network, which is a UK-wide support network for LMCs. And we're going to put a section on our website where we list case studies where people have done some actions with their ICB, or sometimes in response to their ICB. We're going to put all of our enhanced service costs and tariffs in there, and we're going to put our SLAs in there, and we're going to share them so that, again, we can start comparing what kind of work people are doing and for what money. But we're also looking at other cost saving measures. So we have had someone say they can save lots of money for underclaimed PPA. Now, they've got a waiting list to see people, but we have a discussion with them about this. And that might be something that practices want to take them up on. And underclaiming of enhanced services. So again, we've seen examples in the south where there are people working on this and devising ways of catching codes that haven't been captured for the claims, and therefore saving practices money. So we're prepared to pay for that on the basis that we hope that will overall save more money for practices across the ICS than it costs us to pay, because that way overall serving you as our practices, it's been worthwhile and there's a return on investment. So we want to see more of this kind of stuff, how we increase the sustainability, by chipping away, by getting more money for the services you do, and finding gaps where perhaps you could get more money. And mobilizing practices to serve notice warnings or serve, either serve warnings or just basically serve notice completely on enhanced services. And I'm going to give you an example of this in a sec. So I don't know if you can see this. I will talk you through it in case you can't, because it's quite small on my screen. But this is a poll that we ran on the WhatsApp group. Now, if you know about this WhatsApp group, great. If you don't, consider joining it. There's 413 members on it this morning when I checked. And these are all GPs and managers for the most part, which is a good number. That's going pretty well so far. That's not far off 50% now of GPs and PMs in Nottinghamshire. So we're doing well. It's an easy way to communicate. But we ran a poll the other week when the COVID LES and the flu LES came out, the vaccination enhanced services came out. Actually, COVID being a DES, not a LES so much. But what it said to us was, okay, you need to go back to the ICB and see if there's any way you can get any more funding. Because we asked a question about whether you're signing up. And on here, 2 said yes, so they're signing up at the rates that were offered. 21 said no, but we would consider doing it if the rates were better. And 12 said no, and you know what, it doesn't matter what you give us, we're not doing it. So that's useful. So that's around about a quarter of people, a quarter of practices across the ICS coming back to us really quickly and saying, well, some of us are going to do it, but most of us are not. So we've now got a mandate from that. And I know it's a small sample, but it does give us something fairly representative that we can go back to the ICB on and say, look, here's your problem. You're going to have to find other ways of funding this or paying for this or getting this done elsewhere, because right now, most GPs are not going to do this in their practice. But you'll get more doing it if you can find a way of funding it better. So we can use that as an example. We've got evidence, and that's what we've always been saying. We need evidence of what's out there so that we can take that to the commissioners and we can see what they want to do with that. And of course, if we're all doing similar things across the country, then we can go back to the BMA and say, look, this will help you when you're discussing with NHS England about if there's a way of getting anything nationally. But let's not wait for the national picture. Let's go locally back to the ICB and say, look, this is our situation, and here are your options. And what I want to do is extend this really for the other enhanced services. So what we're going to do soon, and I know you get surveyed out, and we've got to be careful not to overdo it and get survey fatigue, but we are going to do this approach for the other enhanced services, the local ones. So we're going to ask you about this year, and we said we would do this around the SDS. So we will be looking before October for where you're at in terms of the current year. Are you willing to serve notice on it? Some will, some won't. Are you willing to say very publicly that you won't do it for this cost going forward and you want us to get better? So we're going to give you options, a bit like we did with this one with the COVID enhanced service. We will give you options. Some people will take it. Some people are happy to take the money. They'd always like more, but they're happy to work on the SDS and other enhanced services on the current rates. We need to know that. But we also need to know the number of people who won't, but we will lead this into next year as well. So we're going to do a part that's for this year, this current year, because we need to hold the ICB to account for the fact that practices are falling over and finding it tough. So we need to give them an honest position of where we're at. We are going to be coming out to you over the coming weeks to get this. And we'll use WhatsApp and we'll use Google and we'll use all the different ways of doing it so that if you miss it in one, you can do it on another. But what we do need to do is find out where you're at, where you're feeling about this year, how strongly you feel with the stuff that the accountants produce, but also with a mind to review everything for next year. So we need to get well ahead of this. We need to be here in October talking about next year, as well as whether anyone wants to take action in the current year, and we need to make the right decisions ourselves in your practices. We can't make the decisions for you, but we can give you the chances, give you the options, and make clear what's possible. And I think a lot of the time, what this has done with the polls is it's helped practices to feel supported and to feel there's a weight of numbers, because I think practices will be braver when they feel that a lot are doing the same rather than than where they're at the moment. But that's where we're stronger. And what we've seen over the last couple of weekends with using WhatsApp is that actually when there's a common goal or aim or issue, general practice can stand up together, and it did that the other weekend in Nottinghamshire. That's really powerful. That tells people in the system that you're not a bunch of individual contractors who can't work together. Actually, this says you can be really strong if you get on the issues that you really care about, and we stand together. So we are going to come back at you very soon about enhanced services, but we're going to start with the COVID vaccine one because that was a really useful one, standalone, easy to understand the costs, and you've spoken. So we need to act on that soon. The sustainability survey, we came out to you, and I want to show you that we're doing something with the data. We came out to you over the course of about 3 or 4 weeks, and we asked you to report back on your feelings about your sustainability. 72 practices responded, so that's around 55% of all practices in our area. 26 from Mid Notts, 24 from the city, 18 from South Notts, and 4 from Bassetlaw. So thank you for everybody who came back. And I'm just going to give you a very quick overview of what we got. So 51% had 3 partners or less in the practice. So that already gives us a feel for the makeup of a lot of partnerships. 9 or 12.5% of those who came back to us are single-handed. Now 12, this is worrying. So 12 are considering handing their contract back in the next 3 years. And that breaks down as 4 in this next 12 months, 4 in 12 to 24 months, 4 in 2 to 3 years. And so therefore, we're looking at 12, 13 over the next 5 years. So we're now going back to practices who have said that they're looking to go in the next 12 months to find out what we can do to help, what level of seriousness are we at, what would change things, which in the most case is likely to be national funding. But we need to know more about what's going on and how we can help. And the ICB needs to know what's happening under their watch as commissioners. So within 5 years, we could be looking at up to 17 or so practices. And that's only out of 72 practices who wrote back to us. Now, we could assume that all the other practices, the 40-odd% who didn't respond, are okay and are not experiencing these problems. But it could be that some of the ones who didn't respond are not responding because they just don't have the capacity to do this or the headspace. They might be in this group as well. So this could be the tip of the iceberg. And that's why it's really important that all the work we're doing starts to get impact and that the ICB understands the scale of what's happening in this ICB. We keep hearing a lot about the deficits with the ICB, the ICS deficit, and how they need to work with reducing that. What they've really got to pay attention to is that the deficit's going to get a lot bigger if we don't pay attention to the problems in general practice. That's what we need to be saying back. Now, what was it most at risk to? We asked the question, and most people said it's the lack of national funding. It's your core contract money, your global sum. That's the main reason why you're in the position where you're vulnerable. The rising costs of staff, the lack of funds available to recruit, they all link to the same thing. But these are the main things you said were hurting you in practice. 79% of the practices who responded have reduced or stopped entirely the use of locums due to insufficient funding. I mean, that's massive, isn't it? Nearly 80% of people who came back to us have reduced or stopped their use of locums. So we have a workforce available to work, but we can't afford them. And nearly 40% of practice have had to reduce their regular clinical offering on the day in the past 6 months due to sickness or because of funding issues. So again, we're cutting our capacity. We're just not coping, and that's happening on the day sometimes. Sorry, I know this is a lot of me talking. I promise I will shut up soon. We will have a chance to hear from more people, and we'll hear from James. Now, again, on my screen, I can see it reasonably well. If it's difficult for you, then I apologise. But we're going to send this out to you in our strategy document once, hopefully we sign it off tomorrow night. So you will see all of this and get copies of it. But this basically just says what I've already described. So on the top pie chart, that was the ICBs or the place-based partnership areas now. So Bassetlaw, the blue one, Mid Notts is the red area, orange was city, green was South Notts. The 3 partners or less, that's the whole bottom half of your pie chart in that second pie chart. So they are all 3 partners or less. So that makes up just over half of the complete list of practices that responded. And the purple part on the third pie chart at the bottom there, the purple part are the ones who said they're not looking at any immediate threat to the viability of the practice. So in other words, they haven't declared an issue within the next 5 years where they may hand the contract back. But all of the other coloured ones, so that quarter of the pie chart basically, they're all the ones who've indicated that we're going to have to hand the contract back unless something changes. The top one here was the regular offerings, so how often we've had to change, and more than 10 times is the purple part, so that's still quite a significant part. 6 to 10 times is the green, so six or more times in the last 6 months that you've had to reduce your offering. That's over half of you. And the last one there, so reduced, which was the locum usage, reduced was 48.8%, that's blue, and actually 30.6% in the kind of darker orange or red. Looks a bit red. That's 30.6% who have stopped locum usage. So almost a third of people who came back to us have completely stopped booking locums in the last kind of 6 to 12 months. So, we know why we're in the problem we've got, and you've told us. What else are we doing? I'm nearly there. You might be pleased to know. What else are we doing? We're continuing to do our daily work. So the liaison team, this all happens, the strategic stuff, but we're still working on all the individual issues that come through the liaison inbox. When you call us, when you phone and WhatsApp us and ask us for help and email across, that will never change. That's our kind of core work, bread and butter work. We're publishing our committee minutes. So if you're interested in seeing those, we've had our first meeting a couple of months ago in May, where we wrote the minutes up and put them on the website. So you can see that. We're looking at greater use of social media. Again, interested on your thoughts on this, but there is a feel that more channels to get through and let you know what we're doing would be helpful. So you'll see more coming out from us on various media, Twitter or X being one of those. We've got a new practice liaison support officer. So this officer is someone who would work in the team with Stu, with Emma, with Lucy, and support a lot of Stu and Emma and Lucy's work, really. It will help us a lot with our strategy and tracking what we're doing and keeping us organised. It will also help with some of the practice support and working with our committee. And that advert's just gone out today. So we're hoping to interview them at the end of July and make an appointment from there. And obviously it depends on how quickly they can start. But, we're putting our money where our mouth is. We're doing more than we've ever done before to try and help practices. And it's visible, and it's a promise from us and our new committee to do this. Keeping the action tracker, so over time we will do this monthly meeting and catch you up with what's going on, but you'll have a way, if you're interested in seeing more detailed level about what we're doing with the strategy. And the creation of a GP provider collaborative board to give a stronger voice across PCN's federations and practices with us in the LMC. So we have conversations going on. I'm coming out to PCN meetings. I've got 2 or 3 in the next couple of weeks, and I went to the big NOTS one a few weeks ago as well. And we're trying to create this because we actually think that strength in numbers working with us in the LMC will give us more, both in terms of that access with the other providers, but also with the ICB. The biggest weakness we have is when we get divided and conversations happen in different corridors. Actually, we're trying to get rid of that. And this WhatsApp group, as I say, it's now over 400 members. So this was written a little while ago. So I think this probably tells us that we've had around 30 to 40 new members in the last month. And the hosting of the BMA workshop, the GPC workshop, for anybody who went to that a few weeks ago. And we're going to talk about how we follow up on that. But that, from what I've heard, it went down reasonably well. But there is a mix of feeling on what happens next and the appetite to do anything about it. It's not striking. You can't strike because you're a contractor. You're not a member of staff. Whereas obviously hospital consultants can strike against the NHS because they're their employers and they pay them through the payroll. You're a contract holder with the NHS, so you can't strike, but you can take action. And this is what we're talking about next. So we did this poll. We said, how are you feeling about the GPC options for action following that WhatsApp, following discussions on WhatsApp and following that GPC workshop? And what we got there was 12 people said they were highly motivated and ready to act as soon as possible. 24 said they were motivated but cautious, but they accept the need to act. So 36 of those already are saying we're going to act. We need to act. One was saying that they were a bit unsure, but hoping for further support and a plan so they can understand it. 4 felt low motivation, doubting it would be effective. So it's a small sample out of nearly, around 400 people. But over 40 people, so over 10% of who could have answered that did answer. And for the main, there is a call to action there. There is an appetite to act, but they need more guidance and support. So what we need to do working with you over the coming weeks is to understand what's possible, what you've got the appetite for. And I'll be honest, we talk openly with the ICB as much as we can. There is stuff we don't talk to them about, but we did talk to them on Friday with Dave Briggs as the medical director and Stephen Short as deputy. And we talked about what's happening around collective action. And we were honest and said, well, we can't really tell you. We can't really give you a plan. We can't give you a guide. And to be honest, that's not in our interest to do anyway. What you are going to see, and what is being seen across the country, are lots of little fires, lots of acts of defiance, lots of changes that are not impacting patients directly, but are causing problems in the system from an administrative and management point of view. And it's just starting to get that feeling of GPs taking action, but being really hard to control. And that's kind of what we've got on our side in a way. It's doing things that put things in our hands, put things in your hands. They're not breaking your contract. They're reducing your workload, but they're also saying to the system that GPs won't just keep taking this and their teams won't keep taking this. And that's been the approach nationally so far, looking at a menu of options and setting off lots of little fires everywhere. And it's to give GPC at the BMA the leverage to go back to the government and say, we can stop a lot of this stuff if we get the right settlements, if we get flexibilities over ours usage of staff, if we get a change to the money that comes into practice, we can stop some of this stuff. But if we don't get anything positive, this will carry on and more. We've got the ballot up until the end of the month, and then there's a potential for another phase of action, which we will see. But at the moment, it's all being kept quite close to the chest as to what that would mean. And here's your team. So this was just, again, to reassure you that you have a team working with you on it. We're going to have an additional member over the next few months. But, rest assured, these guys are all working really hard for you in all different roles to try and get you the best that we can in general practice as your LMC. And medical director, you've met James a couple of times now. James is a new role that we only started a couple of months ago. It's a GP on your side, very prominent, and who does know the system well. So, it's to reassure you that we do need to do a lot more. We need to see more impact, really, of our actions. Actually, we're doing an awful lot. What we need to see, and we're restless for as well, is the impact so that you can see the benefits. But things are happening. We are starting to see change, and keep talking to us about what you need from us. I think I've stopped presenting. So perhaps, I guess, if we hear from James, and then I can hand back to you, Emma, in terms of, if people want to talk more about some of this.
Yeah, thanks, Michael. There's no questions or anything in the chat just yet. We've put a link to the open letter to the patients that you mentioned in there for practices to access, along with the WhatsApp group invite. Debbie from Lombard's mentioned there's a current survey for mid-knots practices on NHS health checks. So again, we've put the link to that survey in there, and Stu's linked the committee meeting minutes, how you can find that on the website. So yeah, no questions just yet, but I'm sure there'll be some potentially coming. But James, I'll hand over to you now.
Thank you very much, Emma and Michael. So there's absolutely loads going on. I'm going to try and update you on a couple of things that are really difficult at the moment, and a few things that are going a bit better. But there's certainly things that are taking up time, certainly. First of all, well, quickly, I'm going to try and tell you about the Diabetes LES Fracture Liaison Service, a bit about what's going on at the Woodthorpe. I'm going to mention the NUH Consultant GP meeting that Michael alluded to in there, and also the NHCT, the Nottingham Healthcare Trust engagement meeting as well, because I think they're relevant. First of all, the Diabetes LES. The reality is this has been and is problematic. Two fundamental issues. The LES itself isn't fit for purpose. It's not costed appropriately. Lots of noise, lots of people unhappy with it. And I've been engaged with the commissioners to try and make sure this gets looked at properly before next year. And we're not asked to sign up before it's been properly costed again, so that we're in a much better place going forwards for next year. I've had assurances that's going to happen. I've yet to see anything. I've not been invited to anything yet, but hopefully that's all going to happen soon. The big issue with the Diabetes LES is the care for patients right now. Now, clearly, a LES being a LES means GPs can choose to sign up, and some GPs have chosen not to sign up. and the requirement for the commissioners to provide an equitable service is still there. And we've now got gaps, and we've had gaps for over 3 months. So none of this has been particularly helped by one of the GPs of special interest telling the ICB that most of diabetes is core. It's not been helped by NUH saying to the ICB that they're only going to see certain parts of this group and making a very clear set of exclusion criteria. It's not been helped by the diabetes support nurses saying they're not going to support beyond what they're currently doing. So I've been pushing really hard for the commissioners to come up with some solutions, and they agree that none of this is acceptable. And right now, they're supposed to be trying to create meetings with those practices to specifically look at those groups of people to understand what it is they need to put in place, which we all accept is too slow, too late, but hopefully things will actually start happening. Practice liaison service. Okay, again, this is another tricky one. The service that was run out of East Bridgeford Health Centre was decommissioned in the south of the county without a proper impact assessment, meaning that all these patients are being discharged to their GPs without a decent plan. And the agreement was, as it was being discharged, that patients would either be discharged to their GP if they can be managed appropriately in the community with a full plan, or they'd be referred on to secondary care. As what's happening now, everything's being discharged to GPs. Fortunately, the letters appear to be marginally better from a point of view as a plan as they were to start with after some feedback, but they're not as good as they could be. But they're still not referring on to secondary care. And we've now even had some referrals from primary care to secondary care who've been sent back to us being rejected, with the reason being no increased activity commissioned. Now, that should now be solved. They shouldn't be saying that. They should be running a waiting list as they would do normally. But watch this space. That was only last week. The City Care Service will continue till March 2025, and the new APC guidance for what we're supposed to be doing across the system is being written at the moment and is due sometime soon. And there should be an options appraisal and a statement for what's going to happen across the whole of Nottinghamshire from April. So there is stuff changing. I'm going to carry on feeding back individual cases, which is having some impact. So if there are particularly bad examples you've got of things that are happening, please keep sending them to me because they're really powerful. And when I show them, they do understand, and it does highlight the issues. So please do keep going. Moving on to the Woodthorpe. Woodthorpe is a good news story. So the issues here were mainly around pre-op and GPs being asked to do further tests and further echoes before people could be listed for surgery, creating an additional workload issue. Patients would then often be discharged if those tests were either not done in a timely fashion, not done, or came back suggesting that patients weren't fit to be managed in the Woodthorpe, and GPs were being requested to refer them elsewhere. The Woodthorpe have now come back and agreed that they're going to do all their own tests and also their own referrals. So if people do need to be referred on to other places, they will do all that as well. And my experience so far is I've yet to see a referral come through to primary care since that agreement. But again, please do send them to me if it's still happening. So the GP NUH consultant meeting. So I just wanted to highlight this because I thought it was a really good example, and it's on the back of the weekly interface meetings that we've been doing with NUH, and have been happening probably for a few years now. And I've been attending for the last 3 months. Hussein Mauji, Jen Moss-Langfield, and others have been attending for longer. And it's demonstrating that actually things do change. There's definitely a tanker, trying to shift the oil tanker analogy going on here, because it's slow and it's difficult. And when you've got big numbers like Michael was suggesting, 18,000 staff, getting that message from the top where the agreement is down to the coalface is obviously difficult. But what was nice about the meeting last week is it was well attended particularly by the consultants. I think there were over 60 consultants there. They all demonstrated that they were interested in knowing what they could do to help. Alan Harkin made it very clear that he was leading the team and to try and make that happen. The impacts of the stuff they gave as examples, actually, when you look back at it, were true. And he was making the point that when bad things stop happening, you don't remember them, you just notice other bad things. And for example, X-rays. GP's been asked to follow up X-rays after 6 weeks because there's signs on the film from ED in particular, was a previous problem. And that does appear to have stopped. And when they pointed that out, I think there was an agreement from the GPs in the room that we're not seeing those anymore. it was interesting that they've changed how their electronic TTOs are done. So when the juniors are filling in the TTOs, a physical box now pops up on the screen that says, don't ask GPs to do anything that you can do yourself. And they actually have to click accept to actually get past that point. So it's just a way of reinforcing that some of that behaviour. In particular, things like sick notes get done, as Michael alluded to before, that you get an appropriate sick note rather than just a 2-week sick note and going back and see your GP for the rest. The new email address for feedback, I think, was an important point that they made, as well as using eHealth Scope. And it was really good that the new MD, Manjeet Shahar, was there. And she spoke briefly at the end. She'd only been, it's only day 3 for her, bless her, but she was coming out with a really strong commitment that she really wanted this relationship to carry on getting better, and the more they could do from secondary care to help was important, which was great and great to hear. We're not quite as far advanced with our other hospitals, but those are things we're working on. And I think we need to try and use this as an exemplar system as to how we can improve things elsewhere. So on exactly the same notes, the Notts Healthcare Engagement Meeting. So this was Wednesday. This is the first time this has really happened with Notts Healthcare. Lucy and I went last Wednesday afternoon, and we met with the MD, the deputy MDs, some GP leads, including Laura James and James Reed, who've both been working on mental health stuff. And to be honest, they're all saying all the right things. They're really keen to engage. They acknowledged that actually the meeting, that they'd kind of forgotten that they provide more than just mental health services to us. So I requested that we make this a lot wider, and we bring in all the district nursing and all the other community services that actually interface really quite strongly with general practice. And I've tested with them a couple of early wins, hopefully, because one of the things I've noticed and other people have fed back to me is we've started from the community staff getting things like FRAX scores and use scores appearing in the GP notes, often inappropriately, but it all requires workload to go and look at if there's anything that needs to be done and why we've received them. So hopefully that I'm just going to start some engagement on that and just see if we can find out what's going on and see if we can change some stuff. The plan is for this to engage into a sort of a more useful forum and not just be with the medical directors, but to be with some of the more delivery orientated members of staff, and to improve change and drive some better behaviours. So I think that was the last thing on my list that I was going to try and update. I hope I wasn't talking too fast. I was aware that we haven't got loads of time, so I kind of attacked it. So give some time for questions. Is that okay, Emma?
Yeah, no, that's great. Thank you, James. It's really good oversight of all the stuff that you're doing behind the scenes for practice. So thank you for that. Callie's just put in the chat. Can you say something more about the templates for each department for referral and prior approval forms? Callie, did you want to come in?
Yeah, just at the more and more departments are having individual prior sort of templates that we have to fill in, which are specific to that department, rather than just a standard detailed referral letter specific to the department. And more these prior approval forms, a separate form that we have to fill in, like for hernias, cataracts, and other things. We're often told we don't need to do that prior approval form, but Sherwood Forest specifically, if you don't do it, they just reject the referral and send it back to us.
Okay, so I'll tell you what I know, Khaled, and I'm definitely not the font of all knowledge here, but so there are two separate issues here. There's making sure that we get the right information into the hospitals when we're making a referral, which a detailed referral letter should do just as well. And some of the forms and templates have been driven through poor letters being sent, and actually to try and make sure that we end up with the right information getting to the right place to smooth referrals, which feels to me legitimate. We've also got the sort of drive to make it easier for secondary care to do stuff so they can smooth behaviours, get people to the clinics faster, some of which I don't think is our job. And there's definitely a line there somewhere that we need to improve. From a contractual level, a referral is a referral, and we shouldn't necessarily have to fill in forms or stuff. There's clearly a balance between making a good job of what we do and being professional, and there's and having to do too much. And I think that's being discussed. I think from a a collective action idea with Katie's ideas, this is one of the things on the list that may happen, is that we'll collectively stop using pro formas and start writing letters. So there's a little bit of watch this space here, but I think that's a separate issue to what a good referral looks like. The prior referral forms are separate again. So the prior referral forms are specifically for, there's a document called items of low clinical value, I think it's called, something like that. And things within that list are only commissioned by exception. So you need to have a particular set of statements to be able to follow it, to make sure that they fit. So things like an inguinal hernia isn't operated on unless it is of a certain size or causing pain or something. There's a list of stuff, and that's the reason behind it. Now, whether that's our problem to fill in or whether it's the commissioner's problem to collect that information is a moot point. However, obviously, if we're referring people that don't fit that criteria, it causes difficulty with the patients and creating patient expectations. So I think there is a sort of onus on us to make sure that we're following those guidance. I do accept your point that it's a real pain, particularly when people, if you write a letter that contains all the right information, if it's then rejected because it doesn't. I know in my practice, I've set it up that my secretaries complete the form from using my letter, and if my letter doesn't contain the right information so they can do that, they send it back to me.
I mean, one example is like the opticians. Somebody goes to the opticians, they've got a cataracts. We get a letter from the cataracts people. Sometimes they do direct referrals, but other times they send it back to us, say, please refer to ophthalmologists for a cataracts extraction. But we have to do the prior approval form. So you have to kind of then contact the patient again to get more information. It shouldn't be our job to do that.
No, absolutely. And to be fair, I think that is improving actually, because I think the direct referral from the optician, sorry, I'm tripping over my own words, is starting to work. I think it's patchy. I had a little bit of feedback on that, but I agree. I mean, it's just bonkers, isn't it? Why send a letter to me to send a letter somewhere else using words that I don't understand? Yeah, it's crazy. So, but I'm hoping that is improving.
Sure.
Thanks, Khaled.
Thank you.
Thank you. Is there any other more questions or comments, opinions, or anything anybody wants to share at all? We will be popping Michael's slides in the e-update along with a recording of this session. We're trying to do more updates in our e-update, but changing it so that it's easier to read. We have got our practice manager forum tomorrow morning at 10:30. So if there's any managers on here that haven't got a link to that want to join, please do let us know. And yeah, as Michael said, was this a helpful session? Do you want us to keep having these on a monthly basis, or if you have got any suggestions for what you want to see in these meetings, please do let us know. We want to make them as useful as possible for you all. I'll take your silence as yes, it was helpful. I can see some thumbs up to it. So that's great. But if you have got any comments that you want to share outside of this meeting, please do just get in touch. Oh, Sarah, you had your hand up and then
no, that was a mistake. Sorry, Emma.
No problem.
I meant to do a thumbs up. I pressed the wrong button.
Brilliant, no problem at all. Okay, so we'll end it there then. Thank you everyone for coming along today. Next week we've got Check coming along to talk about services they have, and we're just waiting for confirmation as to whether people from the COVID programme are coming along as well. We're waiting to hear back from them. In the meantime, hope you all have a safe week. Please do get in touch if you need any support with anything. Thank you.
Thanks everyone. Take care.
Thank you all. Have a good day.